Oh, hey, Chris.
Hey Chuck, how are you?
I'm great. How are you?
I'm good. I'm good. I'm in a different location than our usual. Those of you watching on YouTube see this lovely Embassy Suites layout in the background here.
Nice. Yeah, you look very nice. Tell us about where you are.
I am at the what's been, I think, my third trip to the Orthopedic Research Society's Clinician Scientist Development Program. So it's a really cool program, I think, for the people that are interested in working as a clinician scholar when they're out in the wild. And I attended this in 2011 as a
Wow.
resident, sponsored by the American Foundation for Surgery of the Hand. So thank you, AFSH donors around that time, and have come back on the faculty for 3 years now. It's an honor to be invited to come back and to talk about wonderful things like how to start as a clinician scientist, how to get promoted, that kind of thing.
Yeah, and is it every year this conference is held or?
It's every year, and it's in the same hotel. And I've learned a lot of things about the Embassy Suites in Rosemont, Illinois, including that their gym is quite limited in terms of what's available, number of machines available, and what never changes is that orthopedic surgeons want to work out in the morning, so it's always a bit of a shuffle.
Yeah, I can imagine. I can imagine. Um, well, good. Well, we have I think, a very robust set of things to discuss, and I'd love to start with both of our experiences at the American Society of Hand Therapists.
Hand therapist. Yeah,
Yeah.
I really enjoyed the meeting. I was a participant. I was able to watch our research team. Two medical students gave fantastic podium presentations on their research. So thank you to the program chairs for accepting their abstracts and allowing them to present podiums. One of them was on our initiative to understand how we can contemporize outcome assessments after brachial plexus injuries using things like video goniometry, which is interesting. Try to automate some of this process or at least make it more objective down the line. Uh, and Stephen DiMartini gave a great presentation on that. And then Ishan Sane gave a great talk about our work trying to understand how to implement a navigator position for patients with brachial plexus injury. So a new thing for us that is long overdue, somebody who can kind of be a flex player and incorporate some of the elements of social work, some medical aspects of things, patient education, essentially be a closer or somebody who goes the extra mile, gets people across the finish line for things like disability insurance applications, et cetera.
Yeah, navigator positions are interesting, and I'm sure some of our listeners have experience in that there is no question of the value of that role. It helps the physician, it helps the patients, helps everyone in between, but it's not a revenue creating position. And so it's yet another person in the team, and it sometimes it's hard to justify, even though everyone understands the value.
Yes, and that's a long history in things like oncology and cancer, obviously. So Um, yes, the way that we were able to get this done is that we were fortunate enough to get a grant from the Foundation for the Barnes Jewish Hospital to at least get us started, and hopefully we can very, very clearly demonstrate value and try to find a way to fold this person into the team on a more permanent basis.
Yeah, I love that. Love that. What I really enjoy about the ASHT, and I guess I would say hand therapists in general, is their passion for what they do is really cool. And it's demonstrated in many different ways. Attendance on Sunday morning would be one example, and not just attendance. So we had a couple of things Sunday morning, and not only were people there, they were engaged. And really, it's just a great group of people who really care about what they do and how they, make patients' lives better. So I had a great time and always enjoyed ASHT. And it's the second time it's been in St. Louis in recent memory. And I think they like St. Louis as a hosting city.
Yeah, I think it's the size of the meeting fits pretty well for the size of our city. And there's obviously a rich legacy of hand therapists and expertise in hand therapy in St. Louis. So it's great to have them. So I hope they come back because it's always nice to have a meeting at home. It's interesting to have a meeting at home. I had a special companion for the afternoon portion on Saturday. My daughter's soccer game was canceled because the fields were wet. So she came, and my 6-year-old daughter was sitting front and center as we watched our medical students give a talk. They were so kind. They printed out a name tag for her American Girl doll. It was fun. She got to see kind of a piece of what I do at work. So she got to meet quote daddy's work friends end quote, and had a great time. Yeah, I didn't have her stick around for the IC or for the course that Macy and I were were teaching together. Would have been a little bit more challenging, and the meeting organizers were on high alert when they saw a 6-year-old was around, and they're like, "You're going to be with her the whole time." I'm like, "Yeah, absolutely, no problem."
It's so
So
funny.
I can't let you get away without telling us about your cocktail reception. People bought tickets to have an evening with a scholar like yourself. So you were the feature for this ticketed event, and I heard you gave a great presentation.
Thank you for saying that. Yeah, it's the major fundraiser, I guess, annually for the foundation, and it was Friday evening from around 6:30 to 8. And I came down after business school and had a good time. And I talked about impact, how we consider our impact and how we should think about our impact. And again, audience was great. And so I spoke for, I don't know, 35, 40 minutes. And then we talked, there were questions for another 20 or 25 minutes. So really thoroughly enjoyed it. And, hopefully I think it was positively received. You never really know, but I enjoyed it.
Multiple people from various factions of the hand therapy world commented to me about how great the presentation was. So, congratulations. I heard that you had some tough questions that you handled very well. So kudos to that. That's always the wild card about, you know what your talk's going to say and probably how you're going to deliver it, but you never know what the questions are going to be coming from the audience of a group that you're not as familiar with, say, as if you were presenting to a group of hand surgeons or residents or fellows or medical students.
Yeah, that's exactly right. And I think I don't mind looking silly and making fun of myself, which I think is always helpful in the Q&A. And so no hesitancy to say something silly and laugh at myself.
Well, thank you to the ASHT for always welcoming the hand surgeons to come to your meeting, and I learned a ton personally, both from watching the podiums that I was in the audience for, and also hearing the questions that were asked of Macy and me when we were giving our course, and I've always learned a lot from Macy too, as everybody does. I hear she's a bit of a celebrity among the hand therapists for very good reason, given her recurring guest role on the pod. We should have her back. It's been a while.
It's been a while. So on Sunday morning, I walked in a little early before my session with Stacy. Stacy and I on Sunday morning talked about medial elbow injuries and the role of the ulnar nerve. You could have learned something and
I could have, yeah.
in adolescence, and it was great session. So I walked into Macy's room beforehand, and she was in a big room, and there was good attendance, and she's up talking about rehabilitation after free muscle transfer. And I walked in, and then she immediately just stops and waves. It was hilarious.
The old Birmingham hello.
The Birmingham hello. For those of you not aware, Macy Stoner and I met in St. Louis, but we both grew up in Birmingham, Alabama. So should
That's great.
we?
I heard that talk was awesome too. For rehab after a free functioning muscle transfer, very niche topic, but super important if you're investing that amount of time and effort into a procedure like that to make sure that you can get it across the finish line.
Yeah, what I heard was great. Should we start by thanking one of our sponsors?
This is brand new information, folks. The Upper Hand is sponsored by PracticeLink.com, the most widely used physician job search and career advancement resource.
Becoming a physician is hard. Finding the right job doesn't have to be. Join PracticeLink for free today at www.practicelink.com/ the upper hand. All right, let's get into it.
Yeah, so I've had as just like anything in clinical practice, things come in runs. And I've had a run of patients who are undergoing distal ulnar resections, so the so-called Darrach procedure. Um, like any surgery, like a PRC that's been around for the better part of a century, if not longer, and we're still doing it, probably works for some good reason, even though it sounds kind of ridiculous when you're talking about to a patient. So, for example, one of the patients that I performed this procedure on recently had been I think probably one of the most common indications at this point is a patient that is in their 70s who had a distal radius fracture that we went through extensive shared decision making and counseled her about her fracture. And she ended up with what I've called now, and I think others do too, an expected malunion. And, it counseled her about the appearance of the wrist, both coronally and sagittally. But the ulna, while it was prominent, it wasn't the prominence that was bothering her. It was the limitation in forearm rotation. So this is a patient I talked pretty extensively about performing the distal ulnar resection. What's your talk with patients just to start the conversation about what to expect or when to do the surgery, like for that reason, and what reasons to do the Darrach, or just to say it is what it is.
So a DARE in the setting of a distal radius fracture and whether it's postoperative pain or limitation in motion or deformity in the setting of a distal radius fracture. Yeah, I think it's a really important question and concept. I'll say that I was taught don't ever think about a second surgery after a distal radius fracture for at least 1 year. I don't think many of us accept that to be true any longer. I do think the message, though, is important, is be patient before jumping in after a distal radius fracture. I'm not saying wait a year, but be patient. Give the patient a time to get better and don't rush because some things just take time.
Do you think that there's a threshold where you kind of know it's not going to get better?
Yeah, I would say the pain component is most likely to get better over time. I would think that we and our therapy partners probably know by 3 months whether we're going to see improved motion. Is that your sense?
I think so. I think the die is probably cast by 3 months, and then you get a sense of where their motion is going to land, and then also how they can compensate. So if it's truly limited form rotation, you get a lot of wiggle room through the shoulder to compensate. Or if their shoulder's not great, then that clearly limits their abilities to do that. The pain part of it, I think, is more of the wild card, and I think pain is what would push me to potentially consider intervention a little bit sooner. But yeah, I think you kind of know, and I think you start laying the crepe in terms of planting the seeds for discussion at future visits. And most of the times, I'm not seeing just patients with distal radius fractures beyond 3 months, to be honest with you, unless they've got an ongoing issue like something like this.
Yeah, I think that's great. That's really true. What's interesting about range of motion in my mind, I want to hear more about your experience with this patient, is we usually get pronation back pretty quickly after I would say a standard distal radius fracture and treatment with a volar plate, for example. And we might struggle to get supination back. Pronation far more important for daily life, even though patients want their supination back as well. What was this patient's complaint regarding motion?
So this patient's complaint with motion was actually trying to get both pronation and supination. So she was kind of limited in both ranges. And I think it's interesting that we've shifted now to a pronated world, right? With keyboards, I think the teaching before was supination was better for grip and function in daily life, but now with our being behind keyboards for a lot of things, not just for work, pronation becomes more important. Perhaps with devices and texting and using those things more than keyboard may be less important. But she was just all around bothered by it, and I think it's a different ballgame when you've got expected deformity of the radius as opposed to the situation where you've got a volar plate and you've got hopefully anatomic or close to anatomic alignment both coronally and sagittally of the radius.
Now, how do you decide whether to address the distal radius versus addressing the distal ulna, or potentially addressing both? But in this case, it seems like you were totally focused on the distal ulna, which must mean the distal radius, while not anatomical, was still in the realm of acceptable.
Yeah, I think motion arc flexion extension was acceptable for her from a grip perspective, which I think honestly at the end of the day is probably the most important thing for the radius. She was doing well. She wasn't having any signs of the carpal tunnel syndrome that can occur in about 15 to 20% of patients after a distal radius malunion. It really was the ulna. And to be honest with you, in somebody in their 70s, I'm hoping to do one surgery and be done and keep it simple and not have to rely on a protracted rehab.
And how do you think about DARA versus DRUJ release? Now, DRUJ release is not an operation we talk a lot about. Marty Boyer may in our practice may be the most likely to provide that intervention. I will do it rarely. I mean, super rarely, every couple of years. But how do you think about that procedure versus simply the excision of the distal ulna?
To overly simplify it, that's a surgery for a younger person. And I think about it, I've done it, and I've also sent people to Marty to do it. That's a tough case with with less predictable outcomes, I would say. And you really got to hit it hard with therapy. The surgery is just the beginning salvo and the whole thing. And I think it's the ability to know that they're going to go to therapy and that they're actually going to do whatever it takes to get what is likely to be improved but incomplete recovery of forearm rotation.
I
What is
think
your
that's,
take on it?
yeah, I think that's right. I mean, what we know is the DREJ doesn't typically get stiff, and so there usually is an extenuating circumstance, whether leading to prolonged immobilization of the forearm, because most patients start moving at least a little bit right away, and so it's uncommon to have isolated DREJ stiffness, and it is less predictable of an intervention. And while the DARA is far more predictable, it does carry some risks, which I'm certain we're going to talk about.
So if we just kind of veer away from forearm stiffness and we think more about DRUJ instability, is there a role for a DARA in that, or and then what's the role for an ulnar shortening in your practice for in the instability setting? And let's take the TFCC out of the picture because I know you're going to bring up the fovea.
Yeah, we'll take the TFC out of the picture. There is, I mean, obviously the TFCC is in the background, but I would say there is a reasonable intervention, which is a formal ulnar shortening with plate and screws, where you migrate the ulna proximally and therefore you tighten the ulnar carpal joint and the DRUJ. And so some degree of DRUJ laxity is corrected with a formal ulnar shortening osteotomy. And so it is absolutely an option in the setting of a non-arthritic joint and reasonable bony alignment. And it's a really good surgery in those situations.
Do you think that a shortening can improve rotation by getting the ulna to sit more appropriately within the sigmoid notch?
I would say unlikely unless the malunion of the distal radius allows it. But usually a malunion is a three-dimensional malunion, even if it's, say, for example, primarily dorsal tilt of the distal articular surface. But I don't think we usually see improved rotation with an ulnar shortening osteotomy.
Maybe we also probably underappreciate some extension of the fractures into the sigmoid notch as well, which potentially could predilect to DREJ arthritis. Do you think the ulnar shortening is still an option if they've got DRJ early arthritis that's developing, or do you pivot at that point to the DARA?
So I would pivot to Adara 100%. Now, others would pivot to Sove Kapanji. In our institution, that's not been a primary intervention. At the hand study meeting a few weeks ago, a well-respected distal radius authority commented that she particularly prefers Soves. And I just hadn't had the results with that intervention that I've had with Dara, so I don't usually do a Sove.
So can you, for the audience, summarize what a Selve Capanje is? And thank you for clarifying that it's not a Suave Capanje, which is a pet peeve of our partner, Dr. Boyer.
Yeah, that is true. So in the Sauvé, you take the distal radius and the distal ulna, so the very distal aspect of the ulna, and you essentially fuse the DRUJ. So you remove the cartilage between the radius and the ulna at the sigmoid notch. You fuse the distal ulna to the distal radius, and then proximal to that fusion site, you take out a segment of ulna. And so you create a long, wide platform for the carpus and then you allow rotation proximal to that. And so it's again a procedure that's been around for a really long time. It's not laborious. It doesn't take much hardware, but it does move your mobile segment more proximally to allow rotation.
What's the patients bring this up and they ask, why can't you just replace the joint? So, what's been your current indications to send patients to one of our partners for a DRJ arthroplasty? Is there any role for that? And what's your role for that in the practice in general?
Yeah, I listen, I think that is increasingly accepted as a really good operation for patients of all ages. It's not the same as a wrist replacement. And we probably should have a guest on to talk about some of this. It would be interesting. As someone who does it all the time. But a wrist replacement arthroplasty is different. And it's low demand patients only, and lifespan is not great. But the DRUJ arthroplasty can really be long lasting and highly effective. I just tend to attempt a simple approach first, and that's the DARA. And for me, the DREG arthroplasty is a bailout for a failed DARA. How do you think about it?
Same, and honestly, I'm guilty of not learning as much about the DREJ arthroplasties and the wrist arthroplasties because we're spoiled. Marty takes care of all these people, and he's a pretty well recognized authority in this area, and he loves it. And I also recognize at some point I'll need to learn about this, and we'll need to share the load a bit more at some point. So yeah, I think about that in the same way. And just now getting circling back to the DARA. What do you tell patients to expect in terms of either motion or how long it takes to get over the surgery, that kind of thing?
Yeah, I typically maybe, and I might do it differently than you. I typically immobilize for about 4 weeks to allow the soft tissues to stabilize, tighten up a bit. I don't necessarily put them in a Munster or a long arm cast. I just ask them not to intentionally rotate, and they tend to self-regulate in that regard. And then I get them out of immobilization and start rotating. I do think, and maybe we're going to circle back. We should talk a little about technical.
Yeah, absolutely. I think I guess I'm thinking about the pre-op visit and
Yeah,
how you
yeah.
talk to patients, and yeah, I'm a little less restrictive in terms of immobilization. I try to keep it simple, and honestly, if her issue was rotation, I kind of let her rotate right away, because I think that most patients are going to be self-limiting in terms of not overdoing it for activity. Before we jump into kind of technical aspects, I think we should acknowledge our other sponsor. Again, brand new information, Checkpoint Surgical.
Absolutely. The Upper Hand is sponsored by Checkpoint Surgical, a leader in peripheral nerve surgery solutions with a bipolar stimulation probe. Checkpoint Gemini bipolar nerve stimulator, mouthful, provides finely controlled stimulation even at the fascicular level, allowing surgeons to take actions based on the most precise information available.
Learn more at www.checkpointsurgical.com. Checkpoint Surgical, driving innovation in nerve surgery and giving Dr. Goldfarb a whole lot of stuff to read.
Jeez, that was a lot of anxiety trying to get all that out.
Well, you got it. You're good.
I
So
did.
back to our case. Approach pretty simple for me at least. I try to keep it simple. I go essentially on the ulnar side of the dorsal distal forearm, kind of over the prominence of the ulnar head. At the distal aspect, I'm looking out for the dorsocutaneous branch of the ulnar nerve as it starts to make its way from volar to dorsal at the mid-axial line. Anatomy is a little bit distorted given the fact that your ulnar carpal joints distorted with the prominence of the ulnar head. And then I visualize my ECU and use that as my guide.
I like what you said. I will say that it's very satisfying to me when I take a little different teaching approach. So I had a very strange ganglion cyst emanating from the ulnar carpal joint. And so I asked the resident to draw the path of the ulnar sensory nerve, and she's an excellent resident. And she drew it just dorsal, like it was just a straight line dorsal. And it just feels good when you like I don't usually do that, and I'm like, she's gonna remember this.
That is something I do.
That's
So,
exactly right. That's exactly what I was thinking. It's something you would do. And I realized the value. And if she had drawn it perfectly, I would have felt silly and never done it again. But making them draw it on the patient is really impactful.
the other time that I'll use the marking pen, I'll either make a game plan on the drapes in terms of like if we need to stimulate certain nerves in a certain timeline and here are the goals, etc. Or if we're cutting fascia either in a setting of an ulnar nerve transposition and we're releasing the fascia overlying the two heads of the FCU. I like to see if they can see the raphe between the ulnar and humeral heads and have them mark it out on the fascia. Again, total teaching point doesn't change what we do. Makes it look slicker though. And then also releasing a perineal nerve, kind of tracking the course of the deep perineal nerve as it goes underneath all the lateral and anterior compartment musculature, putting dots on the fascia with the marking pen, so as to see where they think they need to release. Because for that one, you do have to be kind of dead on with your fascial cuts to make sure that you're able to decompress the nerve without excessive exposure. So sorry for bringing nerve into our DARE talk, but yes, that's when I
Yeah.
use that.
So I love that. I like your approach using the ECU as a guide. And then quite simply, I try to take my sagittal saw, which I don't always use in different osteotomies, but I use a sagittal saw. I use it just proximal to the articular surface. And I would say that's step one. How do you take out the ulnar head?
So yeah, actually, when I was doing this, a very astute resident, Dr. Ryan Wilbur, is working with me right now. He's fantastic. And we were talking about different approaches to this, and he was mentioning that some folks preserve the ulnar styloid, as part of this. that has not been very helpful to me. And I honestly, I find, I release the periosteum and then I just kind of work my way around the ulna and going distally and try to take everything right off of the bone. And I don't do much handling the TFCC and I make my cut more proximal.
Yeah, look, preserving the ulnar styloid might sound good, but ultimately the styloid insertion of the TFCC is not the stabilizing portion of the TFC. So I don't think that helps. So, like you said, I sharply dissect circumferentially, um, and then make my cut, and I'm done.
Is this a metaphyseal cut, diaphyseal, somewhere in between? Like how far proximal to the sigmoid notch are you going for your cut, or are you just doing a little bit?
Just a little bit right proximal. Are you making it more proximal than that?
I'm more proximal because if I'm trying to gain rotation, I want to leave no question that I'm going to be able to get the rotation. So I tend to make my cut proximal to the sigmoid notch, so that I am honestly one and done. And then obviously you can cut back. For this case, we checked rotation and then we didn't need to cut back more, but you can cut back more. And then as we bring things to a close, I guess I would like to know, as one of the potential issues with this is convergence in the coronal plane. So the ulna converging on the radius, on the AP view. And then also instability of the ulnar stump. You've obviously cut the ulnar bone, and is that stump going to go dorsal and become problematic?
So I think there's two other technical considerations. Paul Mansky used to always release the pronator quadratus from the distal ulna and either just release it to take away a converging force or release it and interpose it between the radius and the ulna. And I'll say I like both of those options. Certainly the release is simpler, but in certain situations, bringing it up between the radius and the ulna makes sense. That's one technical consideration. And the other technical consideration, which I do regularly, especially if there is intraoperative a lot of laxity, I will take a hemislip of of ECU, leave it attached distally, cut it as far proximally as possible, and then drill a hole in the distal ulna and pass it through the ulna medullary canal, out a drill hole dorsally, and suture it back onto itself. I like that option. I don't always do it. Do you do either of those, both of those, neither of those?
I did one of each. So in the last 2 weeks. So, we had a really nice, on one case, we had a really nice, tendinous portion of the pronator quadratus. So that in like insertional portion. And I put an anchor into to the stump of the ulna and then sutured that together to help kind of hold it in place and try to neutralize that deforming force, and also tried to put it over the dorsal side as well to try and keep that down. And then in the second case, I did see that it wanted to drift a bit dorsally, so I did the hemi-slip ECU that you described, and I think it kind of is case dependent.
It's case dependent. And I will say if you do the hemislip, the problem is you never have enough length of the ECU. So
Oh
you
yeah,
really
yeah.
do have to make your incision longer and really split it. And then you need the length to provide a reasonable stability point.
Yeah, that's exactly what we discussed and then also experienced. So making sure we had the length, and then it's nice when you can suture that back down to itself or to the other part of the hemi slip. That's helpful in terms of controlling that sagittal deformity. So I saw you putting your loops on, which means you've got to get to your case. But I think this was a great discussion. If there are listeners that have experience either performing or rehabbing a Darrach procedure, it'd be great to hear from you. So a handpodcast at gmail.com.
Yes, or listeners that don't like the Dara and the problems that you may have experienced with it. It's a controversial operation, let's be honest, and there are problems with it, and that's why not everyone immediately goes to it. But I think in the right situation, it can be a huge home run, kind of like the Mets home run last night to knock out the Brewers. And we're recording.
We talked about not dating the podcast when we record it, but that was pretty incredible. I was eating dinner in a restaurant last night and heard somebody just scream out expletives. Must have been a Mets fan. They were happy expletives. But yeah, I looked up and I said, "Oh, okay, cool. Something. I guess it's October baseball going on."
October baseball, and the Mets haven't had a lot to cheer about for a really long time.
Exactly. They got that playoff pumpkin. I saw that in the locker room. So anyway, enjoy your day. Enjoy your case.
Thanks. Take care.